This is the accompanying presentation for Chapter 18, Coagulation for the Neurosurgeon. Hemostasis and thrombosis are two critical physiological concepts that are essential for neurosurgeons to understand. Poor control of either one can result in significant morbidity and mortality in neurosurgery, resulting from hemorrhagic or ischemic stroke, respectively. The presentation will provide an overview of the classical coagulation cascade and then provide a synopsis of the cell-based model of coagulation. We will then review current platelet inhibitors as well as anticoagulants and look at their molecular mechanism of action. Finally, we will provide an overview of reversal strategies for all antiplatelet and anticoagulants that are currently used in practice today. The coagulation cascade is the product from two groups that developed the model in the 1960s. It consists of a sequential number of steps that involved an intrinsic pathway and an extrinsic pathway. The extrinsic pathway focuses on tissue factor and factor 7 interacting with one another that generates factors 10. Factor 10 then becomes activated and eventually leads to the conversion of thrombin from prothrombin. This initial pathway is thought to produce just enough thrombin in order to excite the intrinsic pathway that can be seen on the left-hand side of the figure, which goes through factor 12, factor 11, and then the production of factor 9 to factor 9A, which was thought to be the step where the prodigious amount of thrombin is generated in order to convert fibrinogen into fibrin. While the coagulation cascade neatly explains the results from a prothrombin time and an activated partial thromboplastin time, it does not describe fully how coagulation occurs in vivo. The cell-based model of coagulation breaks coagulation into three fundamental steps: initiation, amplification, and propagation. Initiation, like the extrinsic part of the coagulation cascades, demonstrates the tissue factor factor 7 interaction that generates a small amount of thrombin. This small amount of thrombin results in platelet activation that then generates a significant amount of thrombin that is involved in coagulation. This thrombin development is further propagated as more platelets become activated. Current platelet inhibitors can be brought into three fundamental categories: P2Y12 inhibitors that consist of clopidogrel or Plavix, prasugrel, and ticagrelor. Both clopidogrel and prasugrel are prodrugs and require 7 days of therapy if we do not choose to load patients in order to become therapeutic in the bloodstream. Ticagrelor is the only one of the three drugs that can be administered where the patient is therapeutic within a day with on-label administration. Aspirin, the most long-standing drug available as an antiplatelet agent, is a COX-2 inhibitor. And then finally, GP2B3 inhibitors, abscimab, eptifibatide, and tirofiban, are parenteral agents that are largely used in acute situations, particularly in neuroendovascular surgery, to either allow endovascular neurosurgeons to place stents acutely or as rescue therapy if the patient develops intraprocedural thrombosis. With respect to anticoagulants, they also fall into several main categories, the most long-standing of which is warfarin, which you can see from the diagram, affects multiple coagulation factors. The most widely used oral inhibitors currently in patients who have atrial fibrillation are the direct inhibitors of factor 10 and include apixaban and rivaroxaban. Low molecular weight heparin is typically used in prevention of DVT as well as treatment of DVT and PE, and fondoparinox is largely seen in patients who undergo orthopedic procedures, especially hip replacements and knee replacements. The final group are the factor 2 or thrombin inhibitors that include parenteral agents, bivalirudin and argatroban, as well as dabigatran, which is the only oral antithrombin agent available. Finally, heparin, the most long-standing parenteral anticoagulant, is also, it binds to factor 2, but at a different site of thrombin compared to bivalirudin, argatroban, and dabigatran. This slide provides an overview of reversal strategies for all the drugs that have been reviewed in this presentation. They are also available in the book chapter themselves and can rapidly reverse the effects of the antiplatelet and anticoagulant agents should the patient develop intracranial hemorrhage or require urgent or emergent surgery. Thank you for your time.